Oh, people are already signing on.
Okay.
Maybe one more minute and then we'll go ahead and get started, okay? Because you know, you have a full presentation, so just give everybody.
Well, if you want
minute.
to tell us when we should do whatever, then let us please know.
Yeah.
So the rest of us mute at this point. Yes, there we go.
Joe Reisman is well muted. Thank you. The power of Zoom. All righty, I think we'll go ahead and get started. Good morning, everyone, and welcome to Grand Rounds. We have a all-star cast this morning to talk to us about what's new in pediatric asthma, and these are definitely the experts. I'm going to introduce our speakers. We have 4 speakers for this morning, as you can see on the title slide here. I'm going to introduce them, and then I'm going to hand it over to Tom Kovesi, who has graciously offered to do our land acknowledgement at Grand Rounds, given his special connection with Indigenous populations and Inuit in particular. So thank you, Tom, for doing that. So I'm going to begin with I'll introduce all 4 speakers, and then I'll hand it over to Tom, and then he will let you know the order of the subsequent speakers. So first we have Dr. Tom Kovesi, who's well known to our Grand Rounds audience. Tom is a past senior author for the Canadian Thoracic Society Asthma Guidelines Committee and is vice chair of the Canadian Thoracic Society Asthma Assembly. He is past chair of the Ontario Thoracic Society. His research interests include respiratory health and indoor air quality in Canadian Indigenous children. Dr. Dana Radhakrishnan is an associate professor of pediatrics at the University of Ottawa and a pediatric respirologist at CHEO, also director of CHEO's asthma program. She is an active member of the Lung Health Foundation in Ontario and the Canadian Thoracic Society, where she is currently co-chair of the Asthma Assembly. At the CHEO-RI, she is also captain of the Data-Driven Discoveries team and the academic lead for research informatics. As an ICES scientist and clinical epidemiologist, her research interests include big data and advanced analytic techniques, including machine learning and artificial intelligence, to understand morbidity and improve healthcare delivery for children with respiratory diseases. Also on the team, we have Andrea Higginson, who has been the advanced practice nurse and certified asthma educator for the asthma program since 2018. Her focus is on providing asthma education to patients, families, and providers in the hospital, as well as in the community. Andrea is involved with the Best Practice Spotlight Organization initiative with the RNAO by being the lead champion for the guideline promoting asthma control in children. She's been invited as a guest lecturer on pediatric asthma at the nursing schools of University of Ottawa and Algonquin College. She is also this year's recipient for the Betty Cannon Award for Nursing. Congratulations to you, Andrea, on that. Mark Tessier is a nurse case manager and certified asthma educator in the respirology clinic. He is also a 36-year veteran at CHEO, a big accomplishment. Mark has worked as a nurse on our inpatient units, formerly known as 6 West, for those of us who were here then, and 4 West. He's also been the CHEO's tracheostomy resource nurse, and in recent years has sported his yellow vest as one of CHEO's epic super users. Over the past 15 years, Mark has made his home in the outpatient respirology clinic as its nurse case manager, during which time he acquired his certification as an asthma educator and has become, along with Andrea, a best practice spotlight organization champion for asthma here at CHEO. So with all that, you can see this group is very well poised to present us what's new in pediatric asthma and help guide us into the future as we're dealing with future cases of pediatric asthma. So over to you, Dr. Kovesi.
Thank you, Dr. Jabbour, for the kind introductions. So I'll do the land acknowledgement. If you go on Google, you will find at least 6 cities in North America named Ottawa. And perhaps you wondered why. In fact, the Ottawa or the Odawa Nation is a Anishinaabe nation whose traditional lands extended from Manitoulin Island all the way to, of course, Ottawa. They were allies of the British during the War of 1812. And after the war, saw increasing encroachment on the lands in Ontario, saw the writing on the wall, and moved to Ottawa, Ohio. They then got encroached from there, moved to Ottawa, Illinois. The American Indian Removal Act of 1830 banned Indians east of the Mississippi, which meant they had to move again, first to Ottawa, Minnesota, Ottawa, Kansas, and then Ottawa, Oklahoma. I doubt that the city of Ottawa has ever invited indigenous chiefs from the Ottawa tribe in Oklahoma to the national capital that's actually named after their tribe. I think we need to do more than acknowledge their lands. We need to understand the history, recognize the harms that institutional racism have done and continue to do to the ancestral peoples of our hemisphere. Chimigwech. So with that, I will move on to our talk. So obviously we'll be talking this morning about what's new in pediatric asthma. In terms of disclosures, I guess I'm the only one who has some from Kovesi Pharma, which are the manufacturers of Alvesco. In terms of our objectives, they are to recognize new drugs and strategies for the treatment of pediatric asthma, understand the role of biologics in the treatment of severe asthma, review the role of asthma education in achieving excellent asthma control, and learn what the new devices are and how to use them. And in terms of the order, I'll be going first, talking about new drugs, followed by Mark Tessier on how to use the new puffers, followed by Dr. Radhakrishnan talking about biologics, and finally Andrea ending with our amazing asthma education program. So one of the impetuses, I guess, and that's a word, for these new asthma puffers has been global warming. Back when Dr. Jabbour and I were residents, puffers were propelled with CFC, which had a major impact on the ozone layer, and the Montreal Protocol in 1987 required that they be phased out. The Kigali Amendment to the Montreal Protocol in 2016 recommended then phasing out the HFA propellant replacements because of their impact as a greenhouse gas. And all of the puffers that you're used to, all the metered-dose inhalers, are currently propelled by HFA. In fact, HFA has 1,000 times more greenhouse gas impact than CO2 does. And one HFA puffer, your standard Ventolin or Flovent puffer, has 20 to 200 times the carbon footprint of a dry powder inhaler. The carbon footprint of one metered-dose inhaler, which is up to about 400 kilograms of CO2 equivalents, is the equivalent of driving a car about 300 kilometers, the equivalent of putting insulation in your house and its effect on energy use for a year, or cutting meat out of your diet. In the UK, HFA puffers account for 3.9% of the carbon footprint related to healthcare, and about 0.03% of total yearly global greenhouse gas emissions. Now, I know 0.03% doesn't sound like very much, but given the discord around the world in terms of success with reducing CO2, every bit helps. So the first of these new, more environmentally friendly dry powder inhalers is a medication called Airmini Respiraclick. Airmini contains the same fluticasone propionate that's in Flovent that all of us are familiar with. And studies have shown using relatively high doses of Flovent or Advair, fluticasone, Airmini is similarly effective. Its effect on morning cortisols in terms of adrenal suppression is similar to the Flovent that all of us are familiar with. And given all the new drugs and devices, I will typically be using commercial names just to avoid confusion. The next dry powder inhaler is called Asthmanex, which comes as a twist inhaler, and it contains mometasone. You're probably not familiar with Asthmanex, but all of you will be familiar with its first cousin, Nasonex, which is mometasone nasal spray. And again, there are studies showing that Asthmanex and Flovent are similarly effective in adults on peak flows, lung functions, exacerbations. There's studies in pediatrics showing that Asthma is effective. However, Asthma, just like fluticasone, can reduce growth velocity. Interestingly, morning cortisol improves a little bit on Asthma. And another study, again in pediatrics, kids 6 to 11 years of age, high doses of Asthma reduced morning cortisols, as we've seen before with fluticasone. Another cousin is fluticasone furoate. So this is a different formulation of fluticasone, which is an ultra long-acting version. And it's available in a pupper called Annuity ellipta. And it's licensed in Canada for kids 12 years and older, as is the case with Asthma. In studies comparing a low dose of what sounds like a low dose of Annuity, 100 micrograms, and a high dose of Flovent discus, 250 micrograms BID, they're similarly effective in terms of lung function, asthma control, exacerbations, and both medications reduced morning cortisols. And one of the key things to remember about Annuity is the lowest dose of Annuity, 100 micrograms once daily, will cause adrenal suppression. There's more puffers available. These are combination puffers. The first one is called Atectura. Breezhaler. It contains mometasone and indacaterol. And again, studies comparing Atectura and Advair found that quality of life exacerbations were similar between the preparations. Trough FEV1, so the FEV1 measured just before 24 hours after the last dose, improved a smidge more with Atectura than with Advair. Then there is Brio ellipta, which again is a once daily medication. And again, on patients who were switched from Flovent to Brio, the risk of severe exacerbations improved significantly. Trough lung function improved. There is a small pediatric study that showed that ECGs weren't affected by Brio. However, again, the issue with Brio becomes that the 100 microgram dose of Brio is a dose that can easily cause adrenal suppression. The other sort of new kid on the block are long-acting anticholinergics. And the one that's been studied most in pediatrics is Spiriva or tiotropium. So for the med students who've done their adult respirology rotation, all of them are familiar with Spiriva as a COPD medication. And it's available in two different devices. One is called a hand inhaler, and the other one is called RespMat. And Mark will talk more about those shortly. There's a number of pediatric studies showing that in adolescents who are symptomatic despite being on an inhaled steroid plus a long-acting beta-2, if you added Spiriva to them, they had about a 7% improvement in FEV1 and lung function, but no real effects in terms of asthma exacerbations. Another pediatric study, these were 400 kids, 6 to 11 years of age, similar criteria. They had similar improvements in lung function, and again, no important effect on exacerbations or quality of life. And in a meta-analysis, there was some evidence that they reduced severe exacerbations, but clearly their effects on exacerbations is probably fairly small. Their effects on lung function is a little bit more impressive. So if you put all this together, this is perhaps a slide to kind of take home with. One of the advantages of many of these medications is several of them are once daily medications, which is cool. Asthma is licensed for kids 4 to 11 years of age. Annuity, Atectura, and Brio, the first two are licensed for kids 12 and older, and Brio's currently an 18 years and older medication. So using in pediatrics is off-label. The key thing to remember with these medications is the higher doses can cause adrenal suppression, and I would avoid using them in pediatrics. One of the concerns that I have personally is many community physicians are used to treating adults and using the adult dose of all of these puffers. And while it may be reasonable for a 60-year-old, it's definitely a problem for using a 4-year-old. We're seeing referrals with those sorts of doses. So really the bottom line is if you're a candidate for Flovent, fluticasone propionate is on label and a reasonable candidate that's better for the environment. Again, Asthma-Nex or mometasone has the advantage of being once daily. Risk of side effects is probably a little bit more than Alvesco. It's available for pediatric use and a reasonable, environmentally friendly alternative, especially for older kids where the risk of growth suppression is lower. Arnudi is a once daily inhaled steroid, high risk of adrenal suppression, really should be used by specialists. Probably that's true for Atectura and certainly true for Brio as well. And Spiriva, again, is a sort of specialty medication, really designed for very severe asthmatics. So I'm going to move to one more topic before I give things over to Mark, and that's the GINA recommendations, which has generated a lot of buzz. And to understand GINA, I need to ask all of you a question. How many eggs have you eaten in the last month? Exactly. And I suspect, unless you're a vegetarian and never eat eggs, or you have eggs every morning for breakfast, you probably don't know exactly how many eggs you've eaten. And that seems like kind of an odd question, but it's highly relevant to GINA. So there are 4 studies that have studied GINA. All of these were in very mild patients. 2 studies in youth 12 years of age and older, 2 were in adults only. But when you look at the inclusion criteria, these were patients who needed Bricanyl, a tributylene short-acting beta-2, 3 of the last 7 days, but not more than 6 inhalations during more than 2 of the last 14 days of the run-in period, or more than 6 inhalations during more than 3 days of the last 15 to 21 days, etc. And unless you are way, way, way smarter than I am, you will never remember these inclusion criteria. And not only that, but they're hard things to ask, and they're incredibly hard things for families to remember. And that's where the egg analogy, I think, becomes very important. In terms of these studies, the first 2 studies were called Stigma 1 and Stigma 2. These were enormous studies that were sponsored by the company that makes budesonide formoterol, or Symbicort. And in Stigma 1, patients were randomized to Bricanyl PRN, Pulmicort or budesonide BID, or Symbicort PRN. And what they found was that on regular Pulmicort, the percentage of weeks that had well-controlled asthma was better on Pulmicort than it was in PRN Symbicort, and better on PRN Symbicort than PRN Bricanyl. The number of patients with a severe exacerbation was similar with regular Pulmicort and PRN Symbicort, and significantly higher on PRN Bricanyl. Similar study to Stigma 2, which was a little bit more of a laissez-faire, less tightly controlled study, found similar things. Lung function improved significantly more with regular Pulmicort than PRN Symbicort. But again, the rate of severe exacerbations was very low, 0.12 per patient per year, with both regular Pulmicort and PRN Symbicort. The third study was an open label study called Novel Smart, similar criteria. And once again, they found that severe exacerbations was significantly higher with PRN Bricanyl than PRN Symbicort, and similar between PRN Symbicort and regular Pulmicort. And the final study, which is important because it was the only one that was not paid for by the manufacturers of Symbicort, again found that the rate of severe exacerbations was actually a little bit lower with PRN Symbicort than regular Pulmicort. So if you put all this together, I think the first bottom line is that among very mild patients with asthma, the risk of exacerbations with PRN Symbicort and regular Pulmicort are similar, and PRN Symbicort was more effective than PRN Bricanyl. There's a bit of inconsistency between the studies, but in general, every other marker of asthma control, lung function, asthma control scores were significantly better with Pulmicort than with PRN Symbicort. One study has looked at cost effectiveness, and interestingly, PRN Symbicort, even though Symbicort costs 2 or 3 times what Pulmicort does, was actually a little bit lower because you used fewer PRN Symbicort inhalers a year than regular Pulmicort inhalers for the same period. I did sort of an on the table napkin comparison. PRN Ventolin and Bricanyl is cheaper than PRN Symbicort, even when you add in a higher rate of exacerbations. So one of the hard things is these guidelines, the GINA guidelines, are written mostly by people who participated in these studies and also were paid for in the course of these studies. And I think most people highly regard their own research. You shouldn't do research if you don't feel that way. And so the risk of conflict of interest in all of these things is significant. And the current GINA recommendation suggests that for GINA steps 1 and 2, the recommended treatment is PRN Symbicort. For step 3, it is regular Symbicort plus PRN Symbicort. For step 4 is regular medium dose Symbicort and PRN Symbicort. And for step 5, it is regular Symbicort plus PRN Symbicort plus tiotropium, Spiriva, and a biologic or maybe a Zithro as an anti-inflammatory. And I think that it's a big world, and I think there's more space for more strategies than the GINA guidelines. And finally, to conclude, I think for a patient who is incredibly non-compliant, PRN Symbicort is better than PRN Bricanyl if the family can afford it. But if you're reasonably adherent, an inhaled steroid is still definitely our preferred strategy. And for moderate or severe patients, the kind of patients who go to the emergency department, certainly we would recommend regular controlling medications over PRN Symbicort. And with that, I'll turn things over to Mark on how to use these inhalers.
Thank you, Tom. Well, certainly we have gone a long way in terms of how we provide medications to our patient population. We certainly do still rely very much on the MDI, our old standard, but there are some new kids on the block that will, with the new kids on the block come new devices or variations on devices that have been made to make it easier for the end user and to also potentially prevent errors on the part of that end user. And it'll be more clear as I go forward. Certainly at this point, I'm going to move on to a demonstration of all of the devices. So if you would like to just make sure that you're on the gallery view so that you can see me, that would be the best and be the most advantageous to you. So I'm going to start my talk by saying, by giving everyone a cautionary note. We must remember that as we move over from MDI, which is the inhalant, to a more powdered form of the medication, we also need to remember that we are dealing with a patient population that is pediatric in nature, and that, as my colleague Joe Reisman so eloquently said recently in clinic, we need to make sure that these individuals are able to use these devices effectively when both well as when they're sick, because certainly in terms of using it, you do require a lot more effort in terms of inhalation. So you do need to keep that in mind. Also, some of the devices that have come forward have features that make it a little bit more difficult for the pediatric population. And even though some of them are geared for the 12 and up, they still have some inherent issues that would make it even difficult for the adult population to sometimes take it effectively. So I'm going to start with our friend, the Twisthailer. And as Tom said, this has been approved for 4 and over. Now, certainly the use of a powdered form inhalant for a younger population does carry with it some issues in terms of the force in which they need to use. But this is basically built on old technology. If you remember our friend Mr. Symbicort and the Turbuhaler, this is very much the same thing. They have cut out some of the steps to make it easier for the end user. So when you remove the cap, it is already primed for you. There's no twisting and turning of the base to prepare the medication. It is a powdered form. And so there too, once you have the device ready, you need to get your lungs ready. You need to do the exhalation, and then take a very forceful, deep, quick inhalation. and then hold your breath for 10 seconds. Now, the deep inhalation would be the part of the process that which might make it more difficult for the younger population that we're speaking of. The nice thing about it is that when you put it back on, the nice little handy dandy counter here counts down. And the nice feature about the twist haler is that once it reaches 0, it kind of locks you out. So it takes away that potential for an individual taking an inhaler or a device when there's actually no medication in it. So that's the benefit of that. Now the Brio Ellipta takes its genus from the old discus, and that it looks very similar in form, but there too, it has been dumbed down to make it easier for the end user. It comes in a nice little packet that you have to remove the device from. And that's important to know, and is that these devices will only last 6 weeks. So the medication inside, once it's removed from the packet, it's important that it be discarded after 6 weeks. So that's something to bear in mind. So when using it, you flip back the cover, it primes the medication. There too, you want to exhale prior to using it. You bring it to your mouth, and just like the twist haler or in a good many of the other devices, you take a nice big forceful inhalation and hold your breath for 10 seconds. Now, one of the features of this device is that they do have a little vent in the front here, and it's very important that that vent not be covered when taking it. So there are 2 little fingers, little hands, even over the 12-year-old mark, it would be very easy to cover that vent and potentially not get the full impact of that medication. The positive thing about this device too is that once clicked, it's ready. It's ready for the next dose. There's a counter on it that will count down. So there too, you will know how many doses you have. One of the things too to remember is that there is not as many doses in this device, so you would have to be changing it more frequently. So if we're talking about the environment, more frequent changing of a device versus an MDI, which one weighs out, it would be interesting to find that out. The next device that we're going to go over is the RespiClick, one of the newer ones that I've seen. It is kind of like your hybrid because it is a dry powder, but it looks like your old MDI. To activate the medication, you bring it down. If you were listening, you did hear a wonderful little click. It does have a little counter as well, which is very beneficial. And in terms of taking it, the positive thing is that you do not need to use one of these to take the medication. So that's a benefit for the pediatric population who loathes carrying these around. You don't need to shake the RespiClick because it is a dry powder. And once you exhale, you bring it to your mouth, and it is a breath activated device. So you pull in, and just like you would the other device that I've shown, a nice deep, quick inhalation. And hold your breath for 10 seconds. Now, there too, they have placed a vent here, which is necessary for the proper functioning of the device. When we play with this in clinic to see, okay, what are the benefits and the shortcomings of the device, it is very easy for an individual to cover up that vent either with their upper lip. So you just need to be mindful of that when checking the device technique for that individual and making sure that that remains quite clear. Very often our pediatric population rushes through that, and you see them and they're not very mindful of that. So you do need to keep that into consideration. You don't put this in water as well as any of the other devices. And you need to discard this after 13 months. So it does have a longer shelf life, which is great. Once you're finished with it, you close it and it's ready for the next delivery. Now there too, if you were to have to give 2 puffs to an individual, you would have to do the open and close before delivering or taking the second dose. There too, for the patient population that we're dealing with, every time I open and close this means that I'm losing a dose. So the number may not be reflective of the amount of doses that you're taking, because little kids like to play with devices, and so consequently you may be losing a good many of those doses if you have a child who's fidgety and likes to play with covers. The more interesting device that's come along is the Respimat. It replaces, to a certain extent, the HandiHaler of the Spiriva, and that it's a much more passive medication in terms of taking it. You have the device here. You need to get it ready, you need to twist it according to the little arrows indicated above. You open up the cover. There's a little button right here. You place it in your mouth and you press. And there too, you take a nice breath. To show you what it actually looks like coming out, I'm going to open and close this. As you can see, it may not be the easiest. It's definitely a very fine mist, so it's a lot more passive in terms of receiving it. There too, a cautionary note is that they too have little vents on the side, which can be easily covered by the lips, so that too needs to be taken into consideration. The one little part about this device is that it does take a little bit more in terms of actually priming it initially. When it comes out of the package, it comes with a little canister as well as these two pieces. You need to be able to push down the device onto the little canister, put it in, put the cover on in the appropriate way, and then to prime it, you really need to be able to turn it once, remove, press down, point downwards, and then provide one dose. Then you have to repeat that another 3 times in order to prime the Respimat. So you do want to make sure that you have somebody who is able to use the device or has assistance in using the device in terms of priming and whatnot. Last but not least, if you are missing the fun function of the HandiHaler, the BreezeHaler is very similar to that. You open it up like this, or you take the cover off and you tilt back the mouthpiece. You place the little capsule inside of it and you put the cover back on and you press quite firmly on the buttons on both sides to puncture that capsule. And then you, there too, exhale and then take a really deep breath in afterward. And then hold your breath for 10 seconds. It does have a little bit of a taste if you're not quick enough. And also the one thing to remember in terms of this is that they encourage you to then look into the device, see if there's any residual medication still left, and repeat the inhalation if necessary. So that's our quick little overview of the medications. And so now I will pass my my baton off to Dr. Dana Radhakrishnan, who will talk to us about biologics.
Thanks very much, Tom and Mark, for the tour de puffers. There's lots of medicines. I'll be honest, I still don't have a good handle on all of them, but you know, within our clinic, there's certainly resources. If anyone was curious about any of these medications, you could give us a call. But I'm going to skip, come to the exact opposite end of the spectrum that Tom had left off with, very mild asthma, and sort of switch gears and talk about severe asthma and touch on biologics as well. So just to take a step back, a little bit of epidemiology, you always have to get that from me during a talk. Just to remind us all what we're talking about here. Asthma is a leading cause of hospitalizations in Canada. It's the most common globally the most common chronic disease in children, and affects severe asthma, however, only affects about 5% of those with asthma. Yet it's responsible for 50% of asthma-related healthcare costs, and this is in the form of acute care visits, hospitalizations, and medications. Severe asthma is particularly important in children, I would say, because it can lead to permanent changes in the structure of the lung. And we call this airway remodeling, which then can affect lung function permanently. And this extends into adulthood with, in some cases, of very severe asthma, significant morbidity and problems as adults. Severe asthma is also associated with impaired quality of life, and unfortunately, even as of today, is still associated with death. In Canada, we have about 250 people who die of asthma each year. We have had children, unfortunately, within our CHEO asthma clinic who have passed away in the last 5 years. And what's particularly tragic is that in most of these cases, these deaths are preventable if we can improve management and ensure good access to care. So what is uncontrolled asthma? What is severe asthma? These are actually two important terms to distinguish. If we were to look at all people with asthma, apparently about 50% or more, in fact, have uncontrolled asthma. What that means is that they may have symptoms more than 2 times a week. Symptoms would include cough, wheeze, shortness of breath, limitation on activities, or needing their short-acting bronchodilator, that blue puffer, more than 2 times a week. They may have exacerbations, and if they have 2 or more courses of systemic corticosteroids per year, that means their asthma is uncontrolled. If they have 1 hospitalization per year, their asthma is uncontrolled. And if we happen to measure lung function, if their FEV1, forced expiratory volume in 1 second, is less than 80% of their personal best, their asthma is uncontrolled. But within this group of uncontrolled asthma, there are some who in fact have mild asthma and some who have moderate asthma. So what's the difference there? Mild and moderate refers to how much inflammation is actually present in the lungs, or in other words, how much anti-inflammatory medication, what dose is required to get those symptoms under control. And then we have our 5% who have severe asthma. Some of them may be uncontrolled, some of them may be controlled. And severe asthma actually has a pharmacological definition as well, which is that over the previous year, this patient is requiring high-dose inhaled corticosteroids plus a second controller medication. So this would include our inhaled steroid combination LABA, long-acting beta agonist medications. And if they're at a high dose, that means they have severe asthma. Or if they're requiring systemic corticosteroids for more than 50% of the year. We used to do this more often, treating patients with oral prednisone, for example, very low doses, but that would mean that they're uncontrolled. Thankfully, we don't tend to need to do that very much anymore because of all these new advances in inhaled steroid technology. There has been a relatively recent guideline on the recognition and management of severe asthma by our Canadian Thoracic Society that was published in 2017. And in that guideline, we see the usual asthma management continuum. If you can see my arrow anyways, it's a triangle. It's pretty obvious, this multicolored triangle. If anyone has ever looked at asthma guidelines, you would be familiar with this. And I want to highlight this tiny little peak, this red peak at the top. If I were to expand it, on the first version, it's just called severe asthma with not a lot of direction, but there's been quite a bit of advance in how to manage patients who fall at the top of this peak. And if I expand that even more, this is where we then get into the biologic class of medications, which I'll describe. So when we talk about severe asthma, this is when we start to think about asthma phenotyping. Not all asthma is the same. We all know that children present in different ways. They can have mild, they can have moderate, severe, but even amongst those groups, the type of inflammatory cells that are present in the airways, in fact, are different. Some people think that asthma is not one disease. It's actually many different kinds of diseases that we capture under this umbrella term. If we were to simplify, we can group these types of inflammation into either Th2 mediated or Th1 mediated. And this refers again to the types of white blood cells and immune molecules that are present in the airways. The Th2 pathway largely comprises immunoglobulin E being present as a major inflammatory mediator, as well as cytokines IL-4, 5, and 13. And this is the target of these new biologic therapies. We can also measure other biomarkers in asthma. It's worth mentioning because there may be more implementation of these into clinical practice over time. But, you know, we can do good old allergy testing, either serum or skin prick test to see if there's sensitization. We can measure the IgE as mentioned. Serum eosinophils are actually a very important marker in asthma because they predict response to some of these newer types of biologic medications. We can theoretically measure sputum eosinophils. It's exceedingly difficult to get an expectorated sputum sample on a child, but this is a tool that's used in adults, more so for research, but starting to transcend into the clinical sphere in adults as well. And finally, fractional exhaled nitric oxide. The higher the FeNO, the more airways inflammation there is, and this can be a very useful tool for guiding treatment. We do not have an FeNO analyzer at CHEO. It's on our wish list. I hope we get one soon because I think it would really improve the care for our kids. So just to orient you here on this slide, this is like my little simplified cartoon of an asthma airway. These two lines of pinkish colored blocks represent columnar epithelial cells, which is a type of cells that we have lining our airways. And I've just sort of schematically shown a Th1 kind of a white blood cell and a Th2 kind of white blood cell, but I'll just walk through a little more. If we focus on the Th2 inflammatory pathway, this is responsible for recruiting the eosinophils into the airways. And these eosinophils secrete IL-4, 5, and 13, as I briefly mentioned before. And what do these molecules do? They generate inflammation, they activate more eosinophils, which activate more inflammation. So these are really bad guys when it comes to asthma. We also have the IgE pathway, which if I just remind you about, you know, basic allergy concepts, the IgE bind onto mast cells, cause histamine release, which is another major inflammatory mediator. As far as the Th1 pathway, this is more involving neutrophils and granulocytes. Very difficult type of asthma to treat. Thankfully represents a real minority, but ultimately this is another pathway for inflammation, but we will focus on the humoral, the Th2 side. So what about biologics then? Well, these are medications that are directed against specific asthma inflammatory biomarkers, and I've given you a little tour of what those might be. They're generally administered by repeated subcutaneous injection. The earlier versions could be administered by IV infusion or by intramuscular, but thankfully sub-Q is quite effective. And there are 3 medications that are approved for children with asthma, now 6 years and older. And these are omalizumab, mepolizumab, and dupilumab. The mAbs have arrived to asthma world. So the first one, omalizumab, has been around for a long time, trade name Xolair. It targets the IgE antibodies and essentially sops them all up to reduce inflammation and histamine release, and in fact can cause downregulation of inflammatory cells when it's been used for a long time. As far as its efficacy, there have been a number of studies done both in children and adults showing that omalizumab is effective for reducing exacerbation. So this is one of our most clinically important outcomes to measure. So reducing exacerbations by 50%, but also reducing hospitalizations, day-to-day symptoms. And what's really important for families is the dose of inhaled corticosteroid. Just to remind us, these are children with severe asthma typically who would be started on these medications, and they're likely experiencing side effects of high-dose inhaled steroids. So if we can bring down those doses, that's, you know, really of benefit. These medicines are also shown to be effective for improving quality of life. Omalizumab is administered by an injection every 2 to 4 weeks. In the pediatric age group, this needs to be done in a healthcare setting of some sort, less so at home. And as mentioned, approved for children 6 years and older if, excuse me, we demonstrate a positive skin test or serum test for allergic sensitization, and if they have an elevated IgE. I'll briefly mention that there's a ceiling on how high that IgE can be to give this medication because the dose of the medication is matched with the IgE level, and as the IgE goes up, the volume of medication you have to administer subcutaneously becomes too large and can increase the risk of the side effects, which include anaphylaxis and injection site reactions. Mepolizumab is the second medication that arrived. This was approved in Canada for age 6 and older just in March 2020. It's administered by a sub-Q injection every 4 weeks, and it's in this pre-filled kind of pen type of injection device, which can be administered at home. So it's a really nice one to think about for adolescent patients. This medication targets IL-5, and for someone to qualify to be on this medication, really we just need to demonstrate an elevated eosinophil count, but not a really high one. You know, blood eosinophils of 150 or 300 in the past 12 months. And on our differential, that would look like a 0.1 or a 0.3. So that's not really high. There's no anaphylaxis reported with this medication, and side effect profile is very good. And lastly, we have dupilumab, who is the newest biologic that's indicated now for asthma, though it's been around for much longer, with its primary indication being atopic dermatitis. And in fact, the respirologists have become introduced to this medication by our dermatology colleagues, because many children with asthma also have eczema and atopic dermatitis, some of them severe enough to have been on this medication. And what was fascinating to me, this was, you know, my first taste of it, is that some of my really bad patients with really bad skin, suddenly one in particular came to clinic and his face was no longer red. He was no longer flaking and peeling everywhere. And he told me he was started on a trial on dupilumab for his skin. And very quickly, we were able to wean him off all of his puffer medications for his asthma as well. So certainly quite effective anecdotally, but there's also evidence in a large trial for pediatrics. 400 is a reasonably large trial for children 6 to 11 years old, showing a significant reduction in asthma exacerbations, improvement in lung function, as well as improved asthma control based on questionnaires specific for asthma quality of life. Side effects of dupilumab include increased frequency of upper respiratory tract infections and serum eosinophilia, but without clinical manifestations of eosinophilia. So felt to be a reasonably safe medication. And, you know, these biologics, we have about 15 children in our clinic who are on biologics, and it's life altering for them. These are children, you know, we're a bit apprehensive about starting them. I must admit, we're only gaining our experience now. But, you know, just as an example, children can change from being on very high dose inhaled steroids, experiencing lots of side effects, lots of emergency room visits and hospitalizations, and then within a matter of months being able to participate in school sports. So really dramatic in terms of quality of life for children. And I'll end it with that and transfer over to Andrea.
Hi. Thank you very much, Dana. That was great. So we only have a couple minutes left here today. Thank you so much for joining us. For those of you that don't know and are just joining CHEO over the past 2 years, of course, asthma has not been a real issue over the past 2 years with the pandemic. So to let you all know that we have an asthma program at CHEO. Our mission is to improve the health and well-being of children with asthma in Ottawa and the surrounding regions. The format of our program, the way that we started it, was really tackling asthma admissions at first, and then we moved on to asthma emergency room visits, respirology clinic, and how we provide our asthma education. And then we're going to move forward, hopefully in the future, and really try to tap into resources for the Ottawa and surrounding regions. So the real goal of the program is to improve patient and family knowledge and self-management for asthma. And for intensive purposes of lack of time and stuff, I'm just going to really talk about hospital admissions and what we've done, and also emergency room visits. So to start, emergency room visits, back in 2017, at the very beginning of this program, one of the very best things that was ever done was creating the asthma education order. So what happens right now currently is that any patient that is admitted to hospital with an asthma exacerbation, automatically an asthma education order is hard set in Epic to be submitted. And then at that point in 2018 or so, Mark and I would have been notified that there was a kid admitted with an asthma exacerbation. And then we were offering inpatient asthma education sessions on Mondays, Wednesdays, and Fridays, which was great. However, we did run into a couple challenges, one being that families were just plain exhausted with being admitted to hospital with their kiddos. We couldn't tear them away from their kids because they didn't want to leave them alone. And furthermore, it just was really, really stressful, and it was delaying discharge. So we really at that point started thinking, hey, wouldn't it be great if we could start offering these sessions virtually? Families go home, they're really interested. We'll try and get them as soon as they get discharged, plan it before they go home, and see if that could actually work. And then the pandemic hit and a whole new virtual world opened up to all of us. We all have this new ability. Everyone is way more inclined to doing this virtual world. And so now we really do see that families, the feedback from families is that not only do they seem to be attending more readily, but they just really love this idea of the virtual sessions. So Mark and I have been offering virtual sessions every Tuesday in French at 10 o'clock and at 7 o'clock in the evening, and on Thursdays at 10 o'clock and at 7 o'clock in the evening. So we find that there really has been great feedback, but of course, being an academic center, we have to really look and make sure that this is actually effective. So in 2022, we published a study that looked at really optimizing the pediatric asthma education using virtual platform during the pandemic. And what we found was that comparing patients that have actually had inpatient sessions in person compared to those that had virtual sessions, and whether or not that has an impact on their confidence in self-managing the disease, we really found no difference, which was great. And really, furthermore, the comments from doing the virtual sessions was that families felt safer, they could do it with less stress, they could do it at their own leisure, and also both parents could come, which was a huge asset because, of course, during the pandemic, we do have limitations as to how many family members can come. And with links, well, they can send it out to all family members if they want. All people welcome to asthma education. I'm willing to provide to anybody that's willing to listen to me. So then to talk about what we've been doing in the emergency room, well, in the emergency room, we really, we had to take a slightly different approach, of course, because as Dr. Radhakrishnan mentioned so eloquently earlier, asthma is one of the main reasons that we see kids coming into the emerge. And of course, now over the past 3 months, I'm sure everybody's head's exploding with how many kids are really coming in with asthma exacerbations. So really, but what we did want to focus on, because we wanted to decrease the number of multiple visits that were happening with the kids. So we wanted to be able to have more identifiers of which kids were at risk and how could we provide an intervention with this. So of course, in 2019, our group published a study looking at whether the frequency of ED visits could be a predictor for future hospitalizations or future ED visits. And what we found was that the cumulative incidences of admissions for asthma and for future ED visits increased with the number of previous visits. I know that this sounds all jumbled, but therefore, what that means is the more times a patient comes to the ED, the more likely they were going to keep coming to the ED, which totally makes sense. So we developed what's called a best practice alert. And if any of you are here from the Emerge, I hope it's not the first time that you're seeing this. What we hope is that this pops up, this notice pops up, an alert that says, hey, this kiddo is on their second visit for an asthma exacerbation in the past 12 months, has a PRAM score greater than 3, requiring oral steroids or systemic steroids of some kind, has not had a previous asthma education order submitted, and is not currently followed by respirology, okay? And also, of course, they've been prescribed inhaled corticosteroids. This is really the best practice alert, is to identify kids that would really benefit, their families would really benefit from getting any asthma education. So that's really what we were hoping to achieve with this best practice alert, and that the provider would then send me a little notice that this kid could really benefit from some asthma education. So we're running out of time. I wanted to make sure that we had enough time at the very end to ask questions. Just to quickly say, this was a quality improvement study that we did, and I just wanted to let you all know that the next layer of our intervention is that, yes, we invite families for these group sessions, but the asthma program doesn't stop there. Actually, once a family has attended a group session, 2 months later, because we were finding that families were running into trouble even after getting asthma education, they did feel supported, but they still were coming back to the Emerge at 2 months, at 3 months with another exacerbation. So we found that maybe at that time, it would be great to have a little follow-up, a little asthma reinforcement education at that time. So all families that attend our group sessions I then schedule an appointment for them to have a virtual follow-up with myself alone, and we have a real discussion with the families and the kids and stuff like that, and how things have gone over the past 2 months. And then we'll be able to tell you at our next asthma grand rounds about whether or not this was effective, because this has only started in the past 2 months. We need a little bit of time to see whether or not this really has an improvement. Anyway, so those are the exciting things that are going on with our asthma program at CHEO. If any of you are looking for any other asthma resources or what the asthma program is up to, what we use to keep us all on the same page, I encourage you to go to the clinical teams and programs to really find all the asthma information, and then it'll pop up. You'll see our little asthma program here with all of the tabs, and you'll find information there. And then also our lovely little Mr. Puff that Captain Puff that Mark designed, which is gorgeous. So thank you so much for listening to us, guys, and we're open for questions now. Thank you.
All right, well, that was fantastic. Thank you to all of you, for all of our speakers this morning, for a fantastic presentation. I think you've really highlighted how the respirology program service, and particularly the asthma program, has really continued to innovate, to deliver high quality care, and to be educating our parents and patients and families, as well as all of us, on the latest in pediatric asthma. And as Andrea said, now that patients are mixing again, people are mixing again, we're seeing a lot more exacerbations of asthma. So this is incredibly timely. We know that September is always a peak in asthma, and we're definitely in it. So thank you for presenting. So we do have time for questions. If anybody has questions to any of our presenters, please go ahead. I'm going to monitor the chat as well. Try and make sure I can see your hands up. Maybe I'm going to ask you to take the slides down so we can just go in gallery view. Great. Okay. There is a question here. Could families in remote settings join your family education virtual sessions? Example at Calumet. I don't know who wants to take that one, Andrea or Mark?
Oh dear. Am I muted?
No, you're not muted.
No,
Go
we
ahead.
can hear you.
Yeah, go ahead.
I'm so sorry. Can you repeat the question?
So the question is, could families in remote settings join in your family education virtual sessions? Example, a Calumet.
Oh my gosh. So excellent question. So remember at the bottom of our tier, it said community and then surrounding regions. Of course, there would be circumstances that I would really love to provide education to everyone in Canada if they wanted to, frankly. But we really want to focus on patients at CHEO. So if the patient has a connection at CHEO, if we're doing with exacerbations at this point, it would be preferred that we could do that. But if we can set up remote, that's absolutely, I can definitely send. With the virtual stuff, there's really no limitation as to who we can offer education to at this point.
Okay, thank you. There's another question here from Nisha Dean. Are there any issues using Dupixent or other MABs long-term, like immune suppression or autoimmune disease? Maybe that's for you, Dana.
Yeah, thanks. So the reality is these medications haven't been around for a very long time to know what long-term, side effects might be. We also don't know how long do we need to keep a patient on these medications, and can we successfully wean them off at some point. Omalizumab has been around for the longest. I think somewhere between 15 to 20 years. It's been available for children 12 and older, and more recently 6 and older. Anecdotally, there have been, I think one child who developed a leukemia, and they happened to be on omalizumab as well. Is that a true association or a predisposition or something? Really hard to say. So that's not a well-reported, risk of using these medications. And certainly with the 2 newer ones only available in the last couple of years, and even in adult populations only available in the last 5 years. So we're not at the point where we can confidently speak about very long-term side effects.
I'll just add to that your Th2 immune system was really developed to protect you against worms, parasites. So if you're in Egypt and you're walking places with schistosomiasis, the risk of those sorts of infections does increase with these MABs. In Canada, where parasitic infections are really rare, it's not a major issue.
Thank you. And while we're on the MABs, there's another question about the cost of these biologic agents and whether there's coverage and for kids and would they qualify.
So omalizumab, now I'm going to ask my team to correct me if I'm wrong, because, you know, we really rely very heavily on Mark and Andrea to go through all the paperwork and nuts and bolts of getting kids on drugs, so to speak. But omalizumab is approved and funded for kids 6 and older, if I'm not mistaken. Mepolizumab, definitely 12 and older. I'm not sure about the 6 and older though. And then there's currently a CADITH review in place for, you know, which would be the first step towards getting funding for dupilumab. So it kind of depends on the medication and the age group, but, you know, there's certainly quite a bit of efforts in place to get coverage for families. There's also compassionate release and special exceptions. It takes a lot of, you know, rigmarole and paperwork, but what I'm excited about is that we now have 3 choices, whereas before we only had 1. So somehow or another we can manage to get children on medication.
Yeah, that's great. Thank you. There is a question also about more questions about the asthma education program, particularly whether you accept referrals from the community, and also whether there could be a way to ensure that discharge from hospital would be linked appropriately. So could the Zoom link for the group sessions be added to the standard asthma ABS discharge instructions for inpatients?
So I appreciate that. It's not one standard link. So what ends up happening is that it still is very much patient-based. Patients set in the order, and then I lack of a better word, I collect them, and then I send out one link at the end of every day. Now, in terms of the community, I have really big ideas, and Dr. Radhakrishnan and I have talked about different possibilities about opening up the external website, and you just sign in, you register. We've had stuff with Epic. And as you all know very well, the Epic stuff is, and with the pandemic and stuff, things have gotten really kind of crazy. But the next step is definitely opening up more education for sure for the community. We just have to figure out how that looks.
I'll just weigh in a tiny bit. The reality is we're not offering asthma sessions every single day, you know, through the whole business hours. We only have 2 educators and they have lots of other jobs and roles that they fill. So there is a resource limitation. Having virtual group sessions, you know, certainly opens things up to us. But in truth, the studies that we demonstrated, you know, we have, I can't even tell you, maybe 10 families, 8 families at most in a group session at once, and we have good uptake. But one of the biggest benefits of these comprehensive sessions are they're very detailed and they're individualized even within the group setting. So to provide that to 20 patients, 40 patients, you're going to lose that individuality and it may not be effective. And so I'll be honest, I've been a bit hesitant to really just, you know, share the Zoom link. We have to kind of introduce it slowly. That said, you're welcome to email me. You know, I'm happy to take your emails if you have particular families that you have challenges with. The other thing, this is probably our project for 2022-23, is to develop a video. And this is something that will be accessible on CHEO.net, a quicker little bite, you know, with the key points, maybe 20 minutes long or something, that children who are in the Emerge but don't qualify for our comprehensive program, and certainly children in the community could attend to at least get a little more education from the experts.
Great, thank you.
Also, just to add what Dr. Radhakrishnan said, we're really focusing the asthma education on those kids that are high risk children for real struggles coming back to the emergency room. Yeah. So more of the moderate to severe kids.
Yeah. I'm with you on that. Definitely agree. So we are out of time. There are a few more questions in there. There's a reminder from our ID immunologist to make sure that we are actually promoting vaccination so that we prevent these preventable infections. So that's a message to all of us. There is a question from Melissa, and she has her hand up there about predicting whether there's evidence to predict which children will need ongoing inhaled corticosteroids after their first ED visit with an asthma exacerbation, where I suppose the diagnosis may still be a little bit unclear in the under 6-year-old patients.
So maybe I'll take that one on. It's the short answer is ugh. After first episode, you really don't know. You have to 2 episodes to diagnose asthma. So first episodes are really tricky. And what makes it harder is right now, as Melissa alludes to, we're seeing this epidemic of kids previously healthy arriving to emerge with PRAMs of 11. And I don't think we understand this yet. I don't know if these are kids whose immune systems have been dormant for 2 years, not fighting viruses, and they hit rhinovirus and all heck breaks loose, or quite what's going on. I don't think there's good evidence yet. And I know my own personal approach is if you arrive with a really first severe episode, you end up in ICU or whatever, I would treat with inhaled steroids for a couple of months, just for prudence, see what they do. If they never have another exacerbation again, it's probably not asthma and they can come off after 3 months. And if they go on to having repeated episodes, then they declare themselves as being asthmatic. And I would treat them in, the usual way.
All right. Great advice there, great recommendations. We are past time, so I'm going to have to call it to a close, although there's lots of comments in the chat, and really great kudos for this wonderful presentation. Thank you to all of you for this wonderful presentation and for your ongoing care of these patients and their families, and support to us in caring for them. Wonderful day to all.
Thank you.
Bye-bye.